vir julle wat my dalk nie ken, Hein Odendaal. And it's really a great pleasure for me to give this talk to the department. I've done it quite a few times in the past, and it is very, very exciting for me to share with you information from our Safe Passage study. You probably heard of the study several times, but for those who hasn't seen it before, I'm going to repeat basic information. First of all, I would like to thank all the co-workers of the study. At one stage, we had a personnel of about 45 research workers just collecting the data, and at present we have only a few, and concentrate on the different analyses of the information. My interest in the maternal heart rate started many years ago when we introduced fetal heart rate monitoring, and when we realized that sometimes in case of an intrauterine death, you could record the heart rate of the mother through the died fetus, and many people did cesarean sections for apparent fetal distress and then delivered a macerated baby. We became aware of it and were very careful to ensure that we always heard the fetal heart before we did a cesarean section for fetal distress. But what we also did to get more information on the background, we put a scalp electrode on the fetal scalp in all cases where we have confirmed demise by ultrasound to see what patterns we could record from the maternal fetal heart rate. At that stage, we didn't have an ethics committee, and I'm not quite sure whether it would have been accepted now, but that's what we did in those days, although we explained to the mother very carefully what we did. And here are some of the patterns we found, and in this one could clearly see the uterine contractions there, and then apparent accelerations of the fetal heart rate. But that was actually accelerations of the maternal heart rate recorded via the fetus. And here's another one which looks like a fetal tachycardia, but it was actually a mother with a high temperature. And many people looked at this publication, and one of these figures was used for a very long time in the textbook of obstetrics by Williams. A long period then passed until we started with the Safe Passage study, where we obtained financial support from the NICHD and the NIAAA to look at community-based studies on the role of prenatal alcohol exposure for SIDS and other adverse pregnancy outcomes such as stillbirth. So we then studied the problem of prenatal alcohol, SIDS and stillbirth, the so-called Safe Passage study, and exactly the same study was done in two sites in the Northern Plains, in North and South Dakota, and here in Bishop Lavis. The study was supervised by a steering committee, and then we had, as I mentioned, two clinical comprehensive sites. The Physiology Analysis Center, where Bill Pfeiffer is one of the principal investigators, and then we had the Pathology Center and the Data Analysis Center, who looked at all the information. Basically, we had a multidisciplinary approach to look at the role of alcohol on SIDS and stillbirths as our main outcome, and we looked at different parts of the information like physiology, genetics, and pathology, and we approached it on a biological basis. Now, coming to this part, we also record the fetal heart rate as part of the fetal physiology, and for that we looked at different parameters of the fetal physiology, like the fetal heart rate pattern, the uterine activity pattern, and with the recording with the Monica device, which is basically a prenatal Holter which recorded the raw signals from the maternal heart rate, fetal heart rate, and also uterine activity during pregnancy. And with these recordings, we could also extract the maternal heart rate from all the other raw data we analyzed, and we could get very, very good information on the maternal heart rate. Here's an example of the positioning of the electrodes at recording before 20 weeks. And these are the raw material we collected. That's very clearly the maternal ECG, and that is the fetal QRS complex between that of the mother. We then extracted the data, and here one could clearly see the red lines indicate where the fetal complex was detected to use for further analysis. And we got a lot of detail. For example, the background noise in comparison to the strength of the fetal heart and the maternal heart signals. One could also use the Dawes and Redman analyses to use for analysis of the fetal heart rate. One could use their basic definitions, or you could change the definitions, for example, of accelerations, large or small, and also decelerations according to what you would like to analyze. Furthermore, one could indicate how often you wanted the analysis to be repeated. Here, for example, every 10 minutes, where one could look at the mean heart rate, the basal heart rate, large and small accelerations, short-term variability, and then also the mean minute range, which is an indication of the long-term variability. And the same information could be obtained from the maternal heart rate. And here, for example, the real beat-to-beat variability, the time between subsequent R complexes of the fetal heart rate. And one could also use the same program for further analyses, which I'm not going to refer to later. But this is an indication of an extracted pattern. I've shown you the raw signals, and here's, for example, the fetal heart rate, and then there's also the maternal heart rate pattern, and then the uterine activity pattern. And I think it's very important for us to learn more about the maternal heart rate, that we interpret it correctly, as the latest fetal heart rate monitors also gives a simultaneous recording of the maternal heart rate pattern. We noticed changes in the maternal heart rate, and in this case, it resembles early decelerations of the fetal heart rate pattern. And one of the reasons why one could confuse the maternal heart rate pattern with that of the fetus. Here's another example of maternal tachycardia, where it was more than 100 beats per minute, and one could interpret it as a fetal bradycardia. Here's an example of fetal activity. We used a different software to analyze fetal movements based on the fetal electromyogram. And in this case, it is not really the uterine contractions that one sees, but an indication of the fetal activity, where the pattern of the fetal heart rate very closely corresponds with the activity one sees on the bottom line. Then we noticed fluctuations in the maternal heart rate, sometimes independently, but most often with uterine contractions. And in this case, it's very clear that there are frequent uterine contractions with a high amplitude and clearly associated changes in the maternal heart rate pattern. And we really didn't know what it meant. We didn't know how to interpret it. And we searched the literature and found no help. So we really decided that it is necessary to look at the interpretation and the effects of the maternal heart rate pattern. Here's another example of the maternal heart rate. There is the fetal heart rate very clearly, and one could see frequent changes in the maternal heart rate associated with uterine activity, and then a period of no uterine activity. These are all at gestations of about 34 to 38 weeks, and none of these recordings were actually during labor. And you could see here a very rapid increase in maternal heart rate to 130 beats per minute, and then a rapid decline again, and back to the frequent change pattern. And basically, again, we really didn't know. Unfortunately, we couldn't see the recording in real time because the information was recorded and analyzed only later on, because we wanted for the study to keep all the fetal heart rate recordings blind, not to perhaps intervene unnecessarily in the study. So we can't go back to see exactly what happened with the mother at this particular stage, unless she felt dizzy, or unless she changed position or got up. And here's another indication of the rapid changes in the maternal heart rate that could be seen in recordings under resting positions. The recordings were done with all the mothers in a 13 degrees left or right lateral position, and in a quiet room where there wasn't any apparent interference from the outside. And here's another example of a rapid increase in the frequency of uterine activity with an obvious effect on the fetal heart rate as well. And one wonders what would have happened if this frequent uterine activity would have continued, whether that would have an effect on the fetal oxygenation. But the fetus didn't like it at all because of that deceleration. And here you can see there is an increase in the basal fetal heart rate afterwards, as well as a decrease in the accelerations. But fortunately, it recovered and returned to normal. And here's another example of uterine activity on the maternal heart rate, which looks very similar to late decelerations of the fetal heart rate. We played a little with the moniker, and Franelise did a master's study on the moniker, and it showed that we were very accurate in recording the fetal heart rate pattern from the transabdominal electrodes from as early as 20 weeks. And in this study, we looked at the recording of the fetal heart rate in very small fetuses, and in one case, we recorded the fetal heart rate just after 20 weeks. The baby then sometime afterwards at the interim death, they did an autopsy, and the heart weighed 1.3 gram, and that's the recording we obtained from that heart a few weeks earlier. It just shows you how very accurate the moniker device is in recording fetal and maternal heart rate patterns. Another interesting study was when two Swedish medical students were here, and we were sort of keen to see what happens in the maternal heart rate fluctuations. What they did was to record the maternal and fetal heart rate on the day prior to elective cesarean section. To have patients not in labor, they recorded it in a lateral position, then followed by supine, then the other lateral, and then followed by the supine again. And in about 12% of cases, they found that there were changes in the fluctuations in the maternal heart rate pattern. And in this case, it's quite clear that it occurred during the supine position, but it also occurred during the lateral positions, which shows that supine hypertension is not the only role player in these cases. What we think is that if the flaccid uterus contracts in a lateral position, it causes compression of the posterior large vessels in the maternal abdominal cavity, and that interferes with a return of blood, venous return to the heart. But we don't have an explanation for this, and I'll come back to this later. But we think that fetal size could play a role, and maternal size could perhaps play a role, and we still don't know what the clinical significance of that is, because we haven't examined it in a large number of cases. Now, to move from the fetus to the adult, you all know about the importance of baseline variability as an indication of fetal distress, according to the initial publications of Edward Hahn. Several years later, the intercept changed from heart rate variability in the fetus to heart rate variability in the adult. And there are many articles on the physiological basis and measurement of heart rate variability in humans. There's also a review on the interplay between sympathetic overactivity, hypertension, and heart rate variability in the human. There's also a European task force on cardiology, which defined different measurements of the heart rate variability, such as the standard deviation of the normal to normal interval, or the RMSSD, or the standard deviation of the fetal heart rate, and also fetal heart rate variability. So they have standard definitions for all these time domain measurements, of which we have used some in our subsequent analyses. Here's another review article on heart rate variability, and they look at different factors that could play a role. For example, age and gender. It's less in older people, and it's less in women. It's less in fatigue. Emotions play a role, drug play a role, and then alcohol and smoking also play a role. And it gives you an idea of the prognosis of a myocardial infarction, because if the heart rate variability remains very, very low after myocardial infection, it's associated with a bad prognosis. It's associated with arterial hypertension, different neurological disorders, and it's also associated with the complications of diabetes and renal failure as such, or associated with diabetes. But I couldn't find anything on the maternal heart rate during pregnancy in any of the publications or in any of the reviews. We then decided to do a pilot study where we used our last 503 Monica recordings. We thought that would be our best recordings, because we at that time we should have had great experience in the recording of the fetal heart rate. We looked at fetal sex, birth weight, gestational age at birth, and maternal BMI, because we needed this information to calculate the Z-score of the birth weight for gestational age in order to get an indication of growth restriction at birth. We then calculated the Z-scores for the birth weights using the data from the Intergrowth 21st study to obtain it from them. And then we, and Edward Kisser from the engineering department, play a crucial role here, developed our own software for the analysis of the fetal heart rate patterns and also of the maternal heart rate patterns. And we correlated the fetal heart rate outcome and also the maternal heart rate outcome with Z-scores and birth weights. And if one looks at the distribution of the maternal heart rate during pregnancy, you'll notice that in 19% it is less than the normal, which should have been there, 80 beats per minute. So it remains below 80 beats per minute. And here's an example of the calculation of lost and gained beats. So what he did is he established the baseline maternal heart rate first, and then calculated the amplitude and duration of the maternal heart rate above that mean level. And in this case, again, that's a much longer period. And he did the same with lost beats. So there was, for example, 212 gained beats. There was 447 gained beats. And in this case, 171 lost beats, to give an indication of the changes in the maternal heart rate pattern above the mean or below the mean. We used these indicators indicators of maternal heart rate variability, the standard deviation of normal to normal, that's basically the RR interval, then the root mean square of successive RR interval differences, the RMSSD, and then we also looked at the mean R to R interval to get an indication of the maternal heart rate variability to compare with the eventual fetal outcome. We looked at different gestational ages, and here's an indication of the population we used. For example, the maternal BMI varied from 15.3, so it's a very, very, very lean woman, that's one of the lowest we got, to 49.1. And it's quite interesting to look at the median birth weight. And that's true throughout the study, is the mean birth rate is quite low if one compares it to other populations. So we have a population with small babies on the average. And in this slide, we compared the maternal heart rates between 3 periods, 20 to 24 weeks, 28 to 32 weeks, where we had fewer recordings because that was a different study, and then again at 34 to 38 weeks, and these are the numbers in each group. And you could see that there was a little change from 20 to 24 weeks to the next window, but basically very, very little change from the middle to the last window, which actually shows that much of the physiological changes in the maternal heart rate actually occurred at 20 to 24 weeks or before that time. Important information which we unfortunately do not have, but I think that's very important to know. Then if we look at the standard deviation of the normal to normal, basically it fluctuated very little, but in this case the RMSSD it decreased from the first to the second window, and then basically the same, which gives you an indication of the different changes in the maternal heart rate. If one looks at gain beats, it's difficult to explain. It decreased and then increased again. And it is difficult to say that this is associated with birth weight, because that wouldn't explain that decline. So at present, I do not have an explanation of the changes in gain beats. And if one looks at the lost beats, it's actually different, because there's an increase to the second period and another increase to the third period, which could be associated with fetal weight having an effect on the venous return in the mother. We looked at the different influences of the maternal heart rate, and I'm going to concentrate on the 20 to 24 weeks period, because the information from the next period is basically the same. We need to look at the 20 to 24 weeks period, because information there could help one to identify a patient at risk for poor fetal growth. If one looks at the maternal heart rate and look at the correlations with the BMI, there is a correlation with the standard deviation of the normal to normal, and there is an association with gain beats. How one explained this, I really do not know yet, but there are not many associations with the BMI of the mother, although the BMI of the mother is usually associated with the birth weight of the child. But when one looks at the birth weight, there is a very close correlation with the maternal heart rate, the basal heart rate, and the different parameters of baseline variability, and also with gain beats. And if one looks at the Z-score, the p-values are even more. So there is an association between the maternal heart rate and Z-score, which gives you an indication of fetal growth. There's also the same association, for example, with the mean R2R interval. So this indicates that if certain physiological changes do not occur early in pregnancy, it has an effect on fetal growth at a later stage. And here are the information for 34 to 38 weeks pregnancies, and it is basically the same. I'm not going to repeat it, except for the gain beats and the lost beats, where we didn't find any association with gain beats, but we and also with lost beats. So it's not important at present, the maternal heart rate changes on the growth and birth weight of the fetus. And here's an example of the different maternal heart rate quintiles on the birth weight. And if one looks at the first quintile and compare it with the second one, there's not a significant difference, because there's also an A there, but it differs significantly with the next one. And if one looks again at the fifth quintile, there is a significant difference with the others. So it is clear that there is an association between the maternal heart rate and the fetal heart rate. And when one looks at the birth weight at the later period, one will find the same. There is a significant difference between the lower parts and also the higher quintiles, as one see there. I would have liked to look at the understandable maternal heart rate ranges. So, for example, 50 to 60 or 60 to 70, 70 to 80, because as clinicians, we don't understand the quintiles. It doesn't mean anything to us, but unfortunately, the numbers in certain 10 beats per minute groups are still too small. But we would like to extend this analysis, since we feel that it's worthwhile extending the study to look at all our cases, and not only to the 503. But we will find it quite helpful. Just one thing more, and that is one has to look at the very close correlation between the standard deviation of the normal to normal and the basal heart rate, because the standard deviation of the normal to normal changes negatively as there are changes in the heart rate. So one can't look at the standard deviation of the normal to normal independently without looking at the heart rate as well. So it was difficult for us to distinguish between the effects of those two. What's the most important? Is the heart rate more important, or is the standard deviation of normal to normal more important? And then we looked at the effects of different variables on the birth weight of the fetus. And for example, if one looks at the maternal heart rate and heart rate variability, it explains 44% of the changes, associations of the heart rate with the birth weight of the fetus or of the Z-scores. And when one looks at the BMI and of the mother and the fetus, the role is much less. It's about 26%. So it's easy to conclude that the maternal heart rate, and very closely associated with that, the heart rate variability, as you can see there, they are basically on the same line, the maternal heart rate and the standard deviation of the normal to normal. So we think that the maternal heart rate plays a greater role on the prediction of birth weight than the BMI of the mother, or actually the size of the fetus. And then lastly, a low maternal heart rate at 20 to 24 weeks could help one to identify the pregnancy where there is a greater risk of poor fetal growth, as explained by the red score. So I think this is something that could be investigated in the future. I spoke with Bob Pattinson, and he is quite very interested in this. And one thinks about combination of the maternal heart rate at screening. They do their screening at around 28 weeks to look at the molecular artery Doppler and the maternal heart rate at that stage simultaneously, to see whether that could identify the fetus at risk for poor growth. Because if we look at our causes of perinatal mortality, I haven't shown it here, then placental insufficiency plays a very important role. It's one of the crucial causes of perinatal deaths, and this may help one in the future to identify the risk rather early. One could also look at the risks at 34 to 38 weeks, but it's perhaps too late, and one can't do very much to change. So this is basically what we have. So we intend doing the same analysis in about 7,000 pregnancies to get more information on the value of the maternal heart rate in pregnancy. And the other important thing, lastly, those interested in severe preeclampsia or in preeclampsia will remember there are basically two schools. One emphasizing the importance of the placenta in the development of the preeclampsia, and the other group is looking at maternal cardiac output prior to pregnancy, which could also play a role in the development of preeclampsia. And there are people where they look at the profile of the luteal phase of the menstrual cycle to identify risks for preeclampsia should there be a pregnancy later on. So there's a very close association between the cardiac activity and the perfusion of the placenta. So that's basically all. Any questions?
Interesting, because in the embedded we also have the intraoperative doctors and the doctors of these pregnancies
Yes, yeah.
At that stage or later. So I think in addition to looking at the 7,000 that
Yes.
Monica, it would be interesting to look at the 1,200 where we have both the Monica and the doctors.
Yeah, exactly. Yeah. Yeah. We are at present, Lucy's working on the database for the 7,000 on comparison between the information we have and the maternal heart rate. So we'll have the analysis of the maternal heart rate, and then I think all the Dopplers. So we thought of having all the Dopplers, perhaps the estimated fetal growth in it, and then also at placental pathology indicating maternal vascular malperfusion. So to see to exactly evaluate the role of the maternal heart rate. I'm sorry that we don't have the maternal heart rate prior to 20 weeks, but that's information we'll never get.
I think it's interesting that the maternal heart rate in the cardiac output and pregnancy maximizes by about 24 weeks. So that's when the maternal heart is going to be reached its highest rate of output.
Yes.
But, so if the maternal heart rate hasn't increased by this time, it means is it either that the maternal heart hasn't adapted to pregnancy? So is it because the maternal heart rate hasn't done what it needs to, or the cardiac output hasn't increased, which causes growth restriction? Was it inadequate placentation, which hasn't? It's a chicken and egg, which is it the cardiac output or poor placenta?
Yes, yeah, that's right. It's going to be difficult to establish what's first. Is it the placenta that's sort of first, or is it the cardiac output, or is it a combination of the two? And I'm not quite sure with the data we have how we are going to distinguish between the two. But it's two very important questions we need to ask. You're absolutely right. Okay, well, thank you very much.